Okay, so this is just a short lecture. Okay, this used to be a longer lecture. Okay, but because I'm also your lecturer in general surgery on laparoscopic surgery, I already removed the part where we have the introduction to laparoscopy. Okay, so this morning we will just be concentrating on pediatric MIS. Okay. So can you see my slides?
Yes, Photo.
Okay, thank you. Okay, again, please indulge me on this short introduction. Okay, so pediatric MIS, okay, as compared to minimally invasive surgery in the adults, actually took slower to progress. Okay, back in 2006, 2007. Okay, this was the time that laparoscopy was starting to boom in the Philippines. Okay, and at the time I was a senior resident in the Philippine General Hospital. Okay, so our consultants were starting to do laparoscopic surgery. They are starting to practice in pigs. Okay, they had animal. We had an animal laboratory in the university. Okay, and our consultants started to learn. Okay, so this was around 2005, 2006. Okay, um, so being a senior resident, then of course we were part of that growing desire, okay, to practice laparoscopic surgery. Okay, so at during our time, we were already exposed to laparoscopic surgery. Okay, and just to show you the difference, when we graduated in general surgery, we were required to have at least 10 laparoscopic cholecystectomies under our name. Okay, so that's a supervised procedure for the general surgery graduates. Okay, several years later, okay, when minimally invasive surgery boomed, okay, uh, that program was actually removed from general surgery because minimally invasive surgery is now specializing. Okay, so in fact today there are already several centers where you have to take it as a fellowship. Okay, so we have what we call fellowship in minimally invasive surgery. So we have a fellowship like that anymore. Okay, but in pediatric surgery, okay, so I was exposed to laparoscopic surgery for more than 2 years under general surgery. Okay, but when I entered into fellowship in 2007, pediatric surgery MIS was not that established yet. Okay, so in the adults, all the consultants were very excited. Okay, but in pediatric surgery, we only had a handful of consultants. Okay, so these were especially the younger consultants. Okay, so our senior pediatric consultants, for example, were not that enthusiastic. Okay, and you will see part of their psyche, okay, part of the things that they're thinking are actually global. Okay, so for example, this is there is the concept that we are already in the business ever since. Okay, so one of my consultants would say, when I do my herniotomy, my incision is this small. Okay, why do I need to go into minimally invasive surgery? Okay, so pediatric consultants are saying we already have smaller incisions. We therefore have smaller scars already. Okay, so why do we need to do that? Okay, and then there's the concept of course, part of the concept that turned these consultants into minimally invasive surgery is uh, one of the advantages, which is it decreases post-operative pain. Okay, and even the concept of giving your preemptive anesthesia or analgesia. Okay, we've also been seeing that adult patients who undergo laparoscopic surgery are actually staying shorter in the hospital. Okay, uh, uh, but of course, at the start, we had very few cases. Okay, number one, because all the instruments that we have in the operating room are actually for adults. Okay, can you imagine a 60 millimeter instrument? Okay, that's the usual length of the instruments in the adult. Okay, being used for a newborn. Okay, so we didn't have the proper instruments at the start. And compared to adults, we pediatric surgery have no single procedure that propelled MIS. Okay, in the adults, we have your laparoscopic cholecystectomy. Okay, so this was the propelled laparoscopy in the adults. Okay, so this is the reason why there are many adult surgeons, okay, who doesn't need to go into advanced laparoscopy, okay, as long as they are good in laparoscopic cholecystectomy, okay, then their practice is already good, okay. They don't need to go into advanced laparoscopic surgeries, okay. So again, questions, why bother, okay. So with when we started the laparoscopic surgery in the pediatrics, okay, the first question is additional expense. Okay, and we get this from number one, the rent for the lap machine. Okay, so of course, during the start, we hospitals had to buy the lap machine. Okay, and it was very expensive then. Okay, so of course, hospitals would say we need to have a return of investment. Okay, so back then, the rent for use of the lap machine ranged from around 10 to 15,000 per surgery. Okay, so meaning if you would want to have laparoscopic surgery, you would have an additional 10 to 15K upfront. Okay, just to pay for the rent of the machine. Second, most of the instruments were single use. Okay, most of the instruments were single use. So after using one trocar, for example, it is advised that you throw them away. Okay, and you get another new one if you have a new patient. Okay, but of course, being the third world country that the Philippines is, okay, we started to looking for reusable instruments. Okay, so there are reusable instruments, but these are more expensive. Okay, the metal ones. Okay, and of course, we started to reuse even the single used instruments. Okay, so we of course made sure that they are re-sterilized and so that we could use them. Okay. Uh, One factor that actually helped discuss the issue of expense is your shorter hospital stay. Okay. And laparoscopic surgeons at the time, okay, said that you cannot put a price to a to the days that you are not in the hospital. Okay, so for example, a CEO of a very big company, okay, undergoing cholecystectomy. So if you undergo the traditional open cholecystectomy, okay, you would need at least around 5 to 7 days in the hospital. Okay, so can you imagine this CEO leaving for 5 days his work in the company? Okay, so that could relate to several thousands or probably even millions of loss for the company. Okay, and if you compare that to laparoscopic surgery, where a CEO would be in the hospital for 1 to 2 days and then go back to work after that. Okay, in the United States, for example, your laparoscopic cholecystectomy is now an outpatient surgery. Okay, so you go to the hospital in the morning, you undergo the procedure. By lunchtime, you can go home. Okay, so that is how it has progressed over time. Okay, and then another issue is it prolongs the procedure. Okay, and I would distinctly remember one of my consultants say, "You're still setting up the lap machine. I'm already done with my surgery." Okay, so for example, we had surgeries in the lab room, and then this consultant would be having the same procedure in an adjacent room, which is open. Okay, and by the time we start our lab machine, our lab procedure, she would be looking at our room and said, "I'm done. You're still starting." Okay, so this just shows how uh, the procedure takes a long time. Okay, so of course, at the start, okay, we took a long time setting up the machine. We took a long time doing the procedure. Okay, but of course, all these procedures really takes time. Okay, but once we have earned some experience, then of course the operative time decreases. So really, especially in pediatric surgery, it took us from curiosity to standard of care. Okay, so at the start, not all pediatric surgeons were really interested in laparoscopic surgery. Okay, but of course, as medical technology came in, then we are able to show that laparoscopic surgery can be equivalent to your open procedures. Okay, and now we are to navigate the steep learning curve. Okay, of course, we are now teaching our fellows. We are teaching our even our general surgery residents, for example. Okay, techniques. Okay. Also, the community of laparoscopic surgeons, okay, has adopted your simulators, your animal workshops, okay, and has taken our trainees as assistants. So, for example, when I do my laparoscopic procedures, okay, even if I do it outside the Region 1 medical centers, Region 1 medical center, I call my residents, okay, to assist. Okay, don't need to go through that. Okay, of course, the ideal pediatric MIS training, you have laparoscopic simulations, animal workshops, and supervised operation. Okay, so there was this one big workshop where we had an animal workshop for pediatric surgeons. Okay, this was way back in 2016. And we actually operated on pigs. Okay, so these are pigs here. This is a pig. Okay, this is me. This was my junior fellow. Okay, he's 1 year younger than me in training. Okay, so we operated on pigs, and we did all the operations that we wanted to do that time. Okay, we did resections, we did anastomosis, we did excisions of organs. Okay, just so we can practice. Okay, we have here one of the very prolific adult laparoscopy. This is Dr. Buenafe helping us, okay, teaching us. Okay, Dr. Buenafe was 2 or 3 years ago was the president of the endoscopic and laparoscopic surgeons of Asia. Okay, ELSA. Okay, endoscopic and laparoscopic surgeons of Asia. Okay, so after some time, pediatric surgeons has identified what procedures could be equivalent to the adult laparoscopic cole. Okay, so that we can have a procedure that would also, let's say, jumpstart pediatric MIS. Okay, so we identified appendectomy. We know that we have a lot of appendectomy cases in the pediatric age group. Okay, so this is one of the procedure that we have identified to be listed under the basic pediatric laparoscopic procedure. Okay, and then diagnostic laparoscopy. Okay, for several procedures. One is for ruptured appendicitis for your undescended testis. Okay, so in undescended testis, if your ultrasound, okay, so for example, you already did a physical exam, okay, and you cannot identify the testis in the inguinal area, the next step would be an ultrasound, okay, and if the ultrasonologist cannot identify testis in the inguinal area or in the pelvic area, then one of our options is your diagnostic laparoscopy. Okay, so we identify, we insert a camera into the abdomen, okay, and identify where that undescended testis may be. Okay, of course, traditionally, after ultrasound, we do a CT scan, okay, to identify where the testis is. Okay, but what is the advantage of a diagnostic lab for your undescended testis? So it can be both diagnostic and therapeutic. Okay, your CT scan is of course just diagnostic. Okay, and even then, your CT scan will only some CT scans will yet not be able to tell us where your undescended testis is. Okay, so of course in surgery, nothing beats direct vision. Okay, where you can see where that undescended testis is. Okay, and what are the possible treatments after diagnosing where your undescended testis is? Okay, so for example, you see that it is in the pelvic area. Okay, but uh, the attachment is so short you cannot actually pull it down into the scrotum. Okay, then we do what we call a two-stage procedure for herniotomy. Okay, so there's a two-stage procedure for herniotomy so that short segment can actually lengthen, and then you will be able to bring down the testis later on. Okay, that's one. Second, if you see that the testis is already fibrotic, okay, or very small as compared to the normal testis, okay, then your therapeutic option at that time is to do an orchiectomy. Okay, so the option is already to remove that fibrotic testis. Okay, and if you remember, okay, the reason that we remove your undescended testis, okay, that's already fibrotic, okay, is because we know that your undescended testis always has that risk for testicular malignancy. Okay, so that is one of the options for your undescended testis. Okay, of course, we've also identified some of the advanced pediatric laparoscopic procedures. Okay, so as I said earlier, not all our laparoscopic surgeons not all of our pediatric surgeons are enthusiastic about lap. Okay, so they can have the option. I don't want to go into advanced laparoscopic procedures anymore. Okay, so some surgeons would are already satisfied with the basic laparoscopic procedures. Okay, but of course there would still be surgeons who will be suckers for advanced laparoscopic procedures. Okay, so my grandma used to love Kevin Costner. Okay, and throughout my lecture, you will see several movies about Kevin Costner. Okay, that are actually very good movies. Okay, if you have the time to watch, you can look for these old movies. Okay, and uh, you can see how good they are. So, for example, this movie, For the Love of the Game, is a baseball movie. Okay, where Kevin Costner wanted to play the perfect game. Okay, so he's what do you call this, a pitcher. Okay, and to have a perfect game is to have all the opponent players not to be able to swing at your pitches. Okay, so if you do not get any one of them to score a home run, then you would have played the perfect game. And in this movie, it shows how he struggled to get that perfect game. So I think this too was the initial struggle of pediatric surgeons. Okay, uh, just so we can practice laparoscopic surgery. Okay, and I will show you a picture later. Okay, just to demonstrate that. Okay, but just to show you. Okay, so this is the timeline of pediatric MIS cases in PGH. Okay, so I was the junior fellow in 2009. Okay, 2009. So for example, if you remember, I said around this time I was already a fourth year general surgery resident. Okay, and in the adult setting, laparoscopy was already booming. Okay, it was already going high. The consultants are so excited. The residents are excited. Okay, and during that time, they were only able to do two laparoscopic appendectomies. So when I was a fifth year resident, I was not yet in pedia surgery at this time. Okay, so they were able to do four colles, one orchidopexy, one Ladd's procedure, and one Heller's myotomy. So Heller's myotomy uh, is surgery for your esophagus. Okay, so in the 2009, so this was the time when I was already a junior fellow, and I was really interested in laparoscopy. Okay, so together with my some of the consultants who were also excited with laparoscopic surgery, so we started to actively look for laparoscopic cases. Okay, so we were able to do appendectomies, cholecystectomies. We were able to do the first laparoscopic adrenalectomy in Philippine General Hospital. I'm going to show you that case later on. Okay. Tank of catheter revisions, one choledochal cyst excision, one resection anastomosis of ileum, one orchidopexy, one splenectomy. Okay. In 2010, this was the time that I was already the senior fellow. So meaning I already had a lot of take on what operations that I would like to make. Okay, so this is just to show you that my senior, okay, the fellow immediately 1 year older than me, was not that into laparoscopic surgery. Okay, so most of the cases were done by me, okay, not by my senior. So my senior actually concentrated on open surgeries. In 2010, so this was the time that I was the senior fellow. Okay, so we were able to do takedown of gastrostomies, esophagogastric cardioplasty, Heller's myotomy, tal fundoplication. Okay, diagnostic laparoscopy and a transverse loop colostomy, orchidopexy, orchiectomy. So this is for your undescended testis. Okay, so as I said earlier, you can either do a two-stage procedure of your orchidopexy or remove the testis. Okay, inguinal exploration and even trauma. Okay. From the two appendectomies in 2007, we were able to do 20. Okay. We were able to do 9 cholecystectomies and 2 of these with common bile duct explorations. A tank of catheter. This is for patients with renal insufficiencies. We were able to do pull through for Hirschsprungs, pull through for imperforate anus, choledochal cyst excision, Meckel's resection and iliac anastomosis, diaphragmatic hernia, and another adrenalectomy. Okay, so what am I saying? Okay, so I'm showing you now. Okay, what are the possibilities for at MIS? Okay, so this, for example, is a slide I borrowed from the internet. Okay, on one lecture stating what are the options for laparoscopy. Okay, and if you look, it's almost the same list. Okay, so in patients with an acute abdomen that you don't know yet what the exact cause is, for your undescended testis, for blunt trauma, staging. Okay, we do that even here in Region 1 Medical Center. Okay, so for example, for cases of lymphomas, okay, where you need to do an abdominal exploration, okay, instead of an open abdominal exploration, we do a laparoscopic abdominal exploration. Okay, sometimes if you need to do a biopsy, you can insert a camera, okay, and then insert your instruments for a biopsy. Okay, you don't need to be doing a very large incision. Okay, so for the therapeutic laparoscopies, we have appendectomies, fundoplication, orchidopexy, splenectomy, pyloromyotomy, etc. Okay, so here Spang's pull through and esophageal atresia. Okay, so of course we cannot talk about pediatric MIS if we do not talk about the birthing pains. Okay, so we didn't have pediatric instruments at first, and I think this is a global phenomenon. Okay, of course, when industry started to make instruments, they were just thinking of the adults. Okay, so around that time, 2006, 2007, okay, the usual camera is 1 centimeter thick, so almost as thick as your thumb. Okay, the camera was 1 centimeter thick. The instruments were 50 to 70 centimeters long. Okay, instruments were either 1 centimeter or 5 millimeter in width. Okay, so 1 centimeter or 5 millimeters, so 10 or 5 millimeters in length, in width. Sorry. Okay, so these were all for adults. Okay, especially in the United States, where one of the procedures that propagated your laparoscopic surgery is bariatric surgery. Okay, so have you heard of bariatric surgery? Okay, so this is a surgery done for very obese patients. Okay, remember, Americans are very obese. Okay, because of their diet. Okay, for example, if you go to McDonald's in the United States, you get a very large Coke. Okay, so our Coke here is a miniature. Okay, even our large cup, for example, is a miniature. If you go to U.S. McDonald's, okay, they have a very large Coke. That is why a lot of Americans are obese. And one of the procedures that actually skyrocketed your laparoscopy is bariatric surgery. So with that, they really had very large, very long instruments. Okay. Second, okay, of course, we had to select our patients properly. Okay, we were only starting. Okay, therefore, we do not like to have a lot of morbidities from our laparoscopic procedures. Okay, so we usually selected our adolescent patients. So patients who are 10 years old, 11, 12, okay, but not our infants. Okay. And then at the time, for example, we have a restricted ORMAT is OR management team. Okay. And there were no nurses, okay, that are still trained for pediatric MIS. Okay. So again, this is a borrowed slide from the internet. Okay. What are the historical resistance to pediatric minimal access surgery or minimally invasive surgery? Number one, children don't experience pain. That's a myth. Okay, that's not true. Okay, when children are born, their pain receptors are already mature. Okay, so don't say that babies don't feel pain. Okay, it's just that they don't know how to say it. Okay, so if they are in pain, they just cry. Okay, and parents will not be able to say if the child is in pain, the child is hungry, the child is feeling cold. Okay? And then, so as I said earlier, one of my consultants' statement is a universal one. Okay? We already use small incisions. Why do we need to adapt a new technique where we will have smaller incisions? Okay? Next, laparoscopy is only of cosmetic value. Okay? So if you remember my lecture in general surgery on laparoscopic surgery, okay, we have now shown that with the MIS, your physiologic changes are also mitigated. Okay, therefore you can transform for example, a high stress surgery. Okay, because your stress proteins are produced less, they become a less stress surgery. Okay, so of course, not all surgeries have the same stress level. Okay, so for example, if you do a gastrectomy, the physiologic curve would be very high. Okay, the patient would be building a lot of stress proteins. As compared, for example, if you just do an incision and drainage, okay, the physiologic stress level, okay, the graph would be very low. Okay, so laparoscopic surgery is not just a cosmetic surgery. Okay, it does have cosmetic value, okay, but there are also physiologic advantages. Okay, laparoscopic cases don't apply to children. Of course, we know that that is wrong anymore. Okay, there were doctors who asked, "Is it ethical? Is it the right thing to do? Just because we can do it, should we ride the bandwagon?" Okay, so of course, that has already been answered. Okay, with all the advantage of laparoscopic surgery, then the answer here is, of course, it's the right thing to do. It's too expensive. Okay, of course, uh, that is true if you are thinking of the initial, okay, the outright output, the money that you will be spending outright. Okay, but if you think of your savings in terms of the number of days out of the hospital. For example, you're paying your the rent for your hospital room, okay, is 3,000 per day. Okay, so if you stay in the hospital for 7 days, that's 21,000. If you stay in the hospital for 2 days, that's just 6,000. So you already have an advantage in terms of your expense. Okay, so even though you think you are paying outright more expensive because you have to pay for the rent of the lap machine, you have to pay for some laparoscopic instruments or equipments or supplies that were used. Okay, in the end, it balances out. Okay, we don't have small enough equipment. Yeah, that's true. Okay, it's too hard to do, too hard to learn. Part of this is mitigated by what is your pleasure. Okay, if you want to be a good laparoscopic surgeon, then nothing is hard. Okay, if you don't think, I don't think I can use minimally invasive surgery in my practice. Okay, then that's also your choice. Okay, and people will not think less of you. Okay. Okay, the cases take too long to set up and to do. Okay, again, as I said, that's from the start, that's correct. Okay, for example, it's your first lap colectomy. Okay, then it will take a long time. Okay, but if you're starting to do more, then it will take you less time to do it. Okay, so remember our advantages: smaller wounds, fewer pulmonary complications, shorter stay in the hospital. Therefore, you have a quicker return to home, quicker return to school, quicker return to activities, and this is very important. Remember, in pediatric surgery, when we admit a patient, it's not just the patient that stays in the hospital. Okay, that patient will have a guardian. Okay, it can either be parents who are working, okay, or grandparents who will be pulled out from, for example, the parent is still 2 towns away, so they have to pull out the grandparent. Can you please be the one to watch your apo or your grandchild while he's in the hospital? Okay, so you're not only thinking of the parent, okay, but also the guardian. Sorry, the patient, but also the one who is guarding that patient. Okay, so our health system is, for example, if you watch a lot of American dramas, for example, okay, in America, for example, if they admit the child, okay, you don't see the parents guarding the child. Okay, if anything happens to the child, the nurse will have to call, and the parent will have to drive from home. Okay, that's not how our medical system works in the Philippines. Okay, if a child is admitted to the hospital, there's always at least one guardian, either the father, the mother, grandparents, tita, tito. Okay, and you have to factor that in when you are considering the advantages. Okay, or maybe one of you, okay, you have a nephew uh, who is admitted, then your brother or your sister say, can you please be the one to guard your nephew? Okay, so that would mean you will not be able to practice, you will not be able to, if you're still a student, you will not be, probably not be able to attend class, okay, because there's no internet in the hospital, or your internet is slow. Okay, so something like that. Okay, so this is another Kevin Costner film, and it's another baseball film. Okay, so remember, Americans love baseball. Okay, so Kevin Costner here is a corn farmer. So he has a large land, okay, where he plants corn. Okay, but then one day he started hearing voices saying, if you build it, they will come. Okay, and it is alluding to a baseball field. Okay, so he started to transform some of his cornfields into a baseball field. Okay, of course, initially uh, his neighbors were laughing at him or questioning his decision. Okay, but in the end, it became a very famous baseball field. So people would go there, they would have fun. Okay, so just the same. Okay, when we were starting laparoscopic surgery in the Philippine General Hospital, okay, as I said, the lap machines were very expensive then. Okay, so I like this picture because this is a picture showing you the components of the lap machine. Okay, you have the monitor, you have the camera here, you have the insufflation machine here, cautery, etc. Okay, and you see this as one. Okay, but this is actually a byproduct of 10. Okay, so take note. Uh, one company in the US donated 10 lap machines to the Philippine General Hospital. Okay, but not all of these 10 were working. Okay, so we had to spend time looking for which ones are working. Okay, so we ended up with a Frankenstein machine. Okay, so for example, the monitor came from one set, the insufflation machine we took from one set. Okay, in the end, we were only able to actually set up 2 machines out of the 10. Okay, so because I was one scavenging, so pediatric surgery got one of that as their machine. General surgery got one as their machine. Okay. So what is one of the differences in pediatric MIS? Okay. Of course, the insufflation pressures. Okay. For infants, okay, we maintain the insufflation pressure at around 6 to 8 millimeters mercury. For small children, 8 to 12. For older children, that's 12 to 15. If you remember my lecture in general surgery, this is already the adult values. Okay, so in adults, we also maintain the same pressure, so around 12 to 15. Okay, but don't worry. Okay, the machine, if you put in the values, okay, the machine will already monitor that for you. Okay, so you don't need to be looking at the machine every now and then. Is my pressure high? Is my pressure low? Okay, so for example, this is an old stores machine. Okay, you set up what is the maximum pressure that you want. Okay, and then you set up what is the insufflation flow that you want. Okay, so what are the guidelines on the flow rate? So the initial rate is to give it at 0.5 liters per minute. Okay, just to rule out any obstruction. If you see the abdomen starting to insufflate, then you can put it at 0.5 to 2. So in this machine, it's at 1.5 liters per minute. Okay, so that it will start to insufflate your abdomen. Once it reaches the maximum pressure that you put, it will slow down its insufflation. Okay, so most machines now are intelligent. Okay, you just put the maximum pressure that you want, and you put the insufflation rate that you want. Okay, and it will monitor for you. Okay, of course, laparoscopic procedures are also based on technology that is being developed. Okay, in here we can actually see a 3D monitor. Okay, can you imagine that? So if you're already, for example, if you have gone to SM in Manila and you've watched the IMAX movies, okay, where you can actually see the actors, okay, or scenes in the movie, okay, moving out of the screen, okay. We also have monitors like that already. Not in R1MC, okay, but in some hospitals in Manila, they already have this 3D monitors. So you would have to be wearing 3D goggles, okay, just like you wear in IMAX. Okay, so just to give short list of cases, okay. So as I said, one of the basic procedures in pediatric MIS is your appendectomy, okay. In the net, you will be able to find 2 techniques: the in and the out technique. Okay, the in technique is where they do all the appendectomy inside the abdomen. Okay, so insert the camera, insert the instruments, okay, and then remove the appendix from there. Okay, that's the in technique. The out technique is an alternative. Okay, if the appendix is long enough, okay, once you've inserted your camera into the umbilicus, okay, and the appendix is free, okay, you can actually pull that appendix into the umbilical opening, and you can do the appendectomy from there. Okay, so of course we also do that. Okay, depending on where the appendix is, if we open the patient. Okay, so if it is very free appendix, we do the out technique. If it's sometimes the appendix is retrocecal, then we cannot do the out technique. Okay, so this is just to show you the in technique. Okay, so appendix here. uh, the surgeon was already able to put the two proximal ties, okay, and the distal ties so that this appendix will not spill, okay. And this is a laparoscopic scissor, so the surgeon is already cutting the appendix and will be able to deliver this appendix afterwards. Okay, so laparoscopic appendectomy is quite straightforward. Okay, this is one of the cases that is very unique to pediatrics. Okay, your herniotomy. Okay, remember in hernia repair for pediatric cases, we just need to do herniotomy. Okay, and not herniorrhaphy. Okay, so that's the difference. So in herniotomy, you just need to do a high ligation of the sac, okay, because of the pathophysiology. Okay, in adults, you need high ligation of the sac and you need to repair the floor. Okay, so with repair of the floor, that is where we, if you remember the lecture in inguinal hernia, okay, that's where the top and the tap is. Okay, so you have to put a mesh, okay, to strengthen the floor. So that is for adults. For pediatric, you just need to close the hernia sac. Okay, so I'm going to show you pictures. So this was the first technique that was developed. Okay, we insert, once you identified the opening here, okay, you insert your needle holder, okay, and start suturing. Okay, you just do a purse string suture on the area. Okay, so showing you different stages. So at this time, they were already able to close. Okay, this is a newer technique, and this is the one that I'm actually doing in Region 1 Medical Center. Okay, this time you don't need a needle holder because, again, we don't have that instrument for pediatrics. Okay, the needle holder is 1 centimeter in width. Okay, so can you imagine if you're doing a surgery on a newborn with a hernia, okay, and your instrument is 1 centimeter, okay, so it's very hard to do. Okay, with this new procedure, we actually insert. Okay, I don't have the video from the outside. Okay, but okay, imagine. Okay, of course, some we are also here at the outside. Okay, what we do is we insert a needle. Okay, like that. Okay, of course, it's hidden from here. Okay, and then bring it out here. Okay, then we insert another one here. Okay, so this is the proline now that you see. Okay, so all the insertions are from the outside. So we nick the skin from the outside, insert our sutures. Okay, and then I'll show you. So look at this. This is your patent processus vaginalis. Your inferior epigastric vessels are here. Okay. Okay. So let's do that slowly. Okay. So opening of your patent processus vaginalis. This is your internal ring. Okay. The sutures has been placed. Okay. And this is just to show you that if we pull the sutures from the outside, okay, if we pull the sutures from the outside, we will be able to close the hernia. Okay, so the advantage of this is you don't need to be doing your intracorporeal suturing. Okay, so another, okay, we release, okay, just to show you that it's open, and then when we pull, it's closed. Okay, so open, close. Okay, okay, this is another one. Okay, showing just the same. Okay, one of the advantages of your laparoscopic craniotomy is that you can actually see bilateral. Okay, remember in the pediatric age group, the incidence of a bilateral hernia can be as high as 20% in some series. Okay, so we are trying to do a research on that. Um, but of course, it has been stalled a while because of the COVID pandemic. Okay, uh, but we're trying to see the actual rates of bilateral hernia. Okay, so and we can do that via laparoscopy because you can just swing your camera like that, and you will be able to see the other side. Okay, so this is lapaginectomy. Most widely accepted indication is for your unilateral small size, okay, your benign adrenal lesions, okay, and this is a case of a pheochromocytoma. Okay, so pheochromocytoma is the mostly operated case of laparoscopic adrenal procedures. Okay, advantages, it's rapid and comfortable. Again, shorter hospital stay, fewer complications, improved anatomic. So this is a patient where this is a 12-year-old patient. Okay, actually patient underwent open adrenalectomy already for pheochromocytoma in the left. Okay, in the left. Okay, and then after 1 month, the patient had a repeat CT scan, and it actually showed that there is now an adrenal mass in the right. Okay, so we actually did a laparoscopic adrenalectomy on the right. Okay. So what are we doing in R1MC right now? Okay, just give me additional 5 minutes. What are we doing in the Region 1 Medical Center right now? Of course, we're doing appendectomies, okay? Simple and complicated. And the most advantage from laparoscopy is actually your complicated or your ruptured, okay? Because if you have a simple appendicitis, then you just have a very small incision, whether it's open or not, okay? But if it's a ruptured appendicitis, then you know that you need a very large incision. Okay. But if we do laparoscopy, the incision would be the same, even it's simple, even if it's ruptured. So that is why you gain better advantage for your rupture. Okay, we're doing herniotomies before the second surge. Okay, before the second surge, we were doing almost 2 to 3 cases per week. Okay, but we had to stall because of the second surge. Okay, so probably when everything's a little stable now, then we will be going back to that 2 to 3 cases per week. Diagnostic laparoscopy, tumor staging, undescended testis, pull through for Hirschsprungs and imperforate, and manual reduction in intussusception. Okay, so in summary, okay, we still lack enough experience. Okay, but we're doing the procedures. Okay, we're learning from them, so we are on our way. Okay, of course, as compared to other institutions in Manila, where they have several pediatric surgeons, okay, then of course their numbers would be higher. Okay, we still lack pediatric instruments. Okay, and I've actually requested a purchase several years ago when uh, there was a time that we were asked what instruments do we need. Okay, and I've listed several pediatric instruments. Okay, but being the government institution that we are, we still don't have those instruments. So as of today, the reason why we're able to do pediatric laparoscopy is because I personally purchased some of the instruments. Okay, so I purchased a 5 millimeter camera. Okay, so I have my own. I have my personal 5 millimeter camera. Okay, meaning the width is 5 millimeter as compared to the 10 millimeter in adults. Okay, and the length is only 20 centimeters. 20, I think 20 to 30 centimeters. Okay, so it's short. And then I purchased my own basic instruments. Okay, these are 3 millimeter instruments. So can you imagine? Okay, the width is 3 millimeter. Width. Okay, the size 3 millimeter. Okay, and of course we're doing this because we are suckers for pediatric laparoscopy. Okay, so that's the end of my lecture on pediatric MIS. As of now, we have not yet adopted robotic surgery. Okay, you probably heard of robotic surgery. Okay, I know there are some of my colleague pediatric surgeons who are doing robotics in Manila. Okay, but it's not yet mainstream. Okay, we know for a fact that one of the delimiting factors of the robotic surgery is the cost. Okay, and for example, in the Gupan, although we have a lot of businessmen here, I don't think any one okay would pay that high okay just to be operated on by robotics. Okay, for example, a lap cole, okay, the usual amount that you will have to prepare is around 100 to 120,000 for lap cole. Okay, for a robotic cholecystectomy, you have to prepare around 750,000. Okay, so can you imagine that? It's almost 7 times the cost. Okay, 7 times the cost. So this is the reason why robotics is not gaining that much ground as much as laparoscopy. Okay, so here we see a picture of a laparoscopic circumcision. Okay, so that's a joke. Okay, that will not that will never happen because it's very easy to do open. Okay, so any questions on the topic? So I'm sorry, Elijah, I was not able to answer your question. If we're going to use 2 sessions, okay. But now that we're finished, the schedule next Friday is actually open. So if some of the consultants are would like to use that time, then you can give it to them. Unless, of course, Dr. Bernabe is still doing Saturday lectures. He's not actually using the Friday schedule, right?
Yes, po. Saturday po siya.
So, if some of the consultants, for example, in general surgery would like to use it, or in orthopedics, or even in anesthesia, that's a free schedule for you.
Yes po, Doc.
Okay? So, okay, one more thing. So if you've heard of the National Vaccination Program, okay, that's for next week, Monday, Tuesday, Wednesday, November 29 to December 1. Okay, for those who are not vaccinated yet, then you have to register online. Okay, you cannot go walk in. You have to register online. Okay, so if you have any lectures or any academic activities, you will be excused from attendance. Okay, but only, of course, for those with a registered online schedule. Okay, so you cannot go walk in. Okay, so no questions. Okay, so if none, then thank you for listening.
Thank you po, Doc.